Keep going. All right. So topics. We're going to go over very quick. I'm really not going to spend much time on it because I did an entire talk just on that. Then we're going to go over coronary disease, the different stress testing. That's where I'm going to spend a majority of my time because board-wise, that's where a lot of the questions are going to come from when it comes to overall testing. I'll touch on MRI just because it is rarely done here. And, Dr. Garcia is probably a better person to hint on that. And then we'll go over, coronary CTAs, the coronary calcium score, some pacemakers. I'll kind of talk more about that in the chest x-ray part, and then event monitors. I'm not going to go over EKGs or even labs. EKGs will be a talk I think I'm giving next week or week after. So here's some objectives. Don't worry about these, but the flow, we're going to go over imaging of the chest x-rays, then the overall, pacemakers, stress testing, MRI, CT, the Holter event monitors, and then echo. So let's start with chest x-ray. So we already know a lot about this. This is what the heart really looks like if you're to use an overlying anatomical image over the chest x-ray. Just remembering that right side of the heart is the right side of the chest x-ray, with the left ventricle pretty much only appearing at the very far left. And then if you were to use a lateral, which we really don't talk too much about, I did, briefly go over it on my chest x-ray talk, but for the most part, I think when we're going over them in our rounds and stuff like that, a lot of us just kind of skim over it. But it's important to know specifically because, if any of you have had a talk from me on rounds, you'll know that I focus on vertebral bodies to make sure there's no pneumonia, because pneumonias will appear where you normally have this whitening into the clear. You'll see that loss of translucency, it becomes more opaque. But this isn't a talk about pneumonias, this is more of a talk about cardiac testing. So the things that we're looking for is not necessarily on a lateral, but on a PA or an AP, we're going to see that pacemaker, as well as potentially some signs that could be suggestive of tamponade, which we know is, fluid that collects. So this is in the pericardial space. So this is a very clear, obvious view of tamponade. You might say, okay, I look at that, it's no joke. Like, how could you miss that? These are the type of chest x-rays you're going to see though on your boards, because they don't want there to be any type of suspicion or there to be any question about it. Because those questions that they write go through so much vetting that they don't want there to be any chance that could be misinterpreted as something else. But when you look on the lateral, you can see this positive radiographic sign with the arrows, right? So you can see this clear lucency. They sometimes called it the Oreo sign. You have what's kind of like a reverse Oreo, but I guess if you're using this as the white and then this is black and then this is black, maybe that's the Oreo. But that's the sign that you would look for in someone that has a pericardial fusion or a tamponade. So if you were just to zoom it in, you'll see that it's very clear that there's that fluid that's showing up there in the x-ray. This was talked about a little 2 or 3 days ago on Monday by Dr. Priyanka, but we kind of went over coarctation, dissections, etc. I think I remember it might have been Dan that mentioned, the rib notching. The figure 3 sign is something that we look for. The rib notching is going to be very hard for you to notice. So they're not going to give you an x-ray just like this and say, okay, what's the diagnosis? They'll give other signs, whether it's, an unequal blood pressures, etc. But just know that when you see this figure 3 sign, which is right here, so this kind of curving in, out, whereas normally it's not going to be this accentuated, that's when you are going to be suspecting that there's potentially a coarctation. So it's very quick because really this intent is not to go over x-rays, but I did want to, kind of make it known that x-rays should be considered on all of our patients who are going through any kind of cardiac workup, because we have on almost all of them coming through the ER. So this was a discussion that came up, I forget what talk it was, but someone had mentioned, I think it was one of the case reports, and someone was saying, how do we, decide, or how are we able to decide if this is a pacemaker or an ICD? And I believe Dr. Duffy was able to shed some light on that. So I wanted to kind of briefly go over it, just knowing for your ICDs, it's basically a battery pack. You're going to use that in our patients that have, very low EF that has not recovered, typically, less than 40% or so. And you're going to be able to tell, because when you see the ICD, it's just going to have the one lead here and then a second lead, and you're going to see this thickened portion of that lead, which is going to kind of increase your suspicion for that, versus when you have a pacemaker, you don't see the thickening of the leads at the very end. So again, if I go back, you can see how there's a radiopaque thickened portion at the distal end of these 2 leads, whereas when you go to the pacemaker, you see that there's no thickened portion. You can still see there's 2 areas here in the atrium, and then looks like it's going into the interventricular septum region, as well as the overall appearance, right? So if we go to the ICD, it's one large battery. You can see the internal components here, but you can see like more of the batteries actually up here, and then you can see what's the internal motherboard for the pacemaker, but it just has a different appearance. So I would just use the leads as your overall way of knowing which one it's gonna be. So if we go to the next slide and we can see the comparison, again, you can see the battery here, the circuitry, the motherboard for the pacemaker, and then for the ICD, you can see it's all kind of in one, but knowing that the ICD is gonna have that thickened wire at the tip will help you decide or know which type of device a patient has of yours. And then just knowing the terminology, I'm really not going to get into this. This is a little more advanced and it's not going to show up in your board. So I really would not commit it to memory. You're going to learn about it when you go through your cardiology rotation, I'm sure. But I just wanted to include this so when you guys go back and I send out these slides through Jody, you'll be able to have an idea when you see it written down on your notes. Or if you want to write it down in the notes after maybe it's interrogated and you find out what type it is, you can then use the appropriate terminology. And the terminology is going to base off of where it is, the atrium and ventricle versus both. And then is it inhibited? So it's inhibiting the signal, or if it's a triggered one based on, maybe, bradycardia. All right, so let's go into some of the diagnostic testing. We're going to go through, functional studies, economic studies. Obviously, when we're doing the diagnostic testing for our patients with this concern for atherosclerotic coronary vascular disease, there's two things we're looking at. We're looking at how well the heart is functioning, and is that there's an issue with the heart itself structurally that maybe is affecting that function in itself. So if we look at the functional, before I go ahead, it's going to allow us to see, is there any evidence of ischemia before we even get into the anatomic look of the heart? And this is how we, we get this through ECGs, right? That's not going to, it might help us localize, which I'll get to on my EKG talk, but it's really just telling you if there is an underlying issue going on with the heart itself. Even the SPECT CTs and the echocardiograms that we get, it's giving you the overall function, not as much of the anatomy as we would like. But if we're thinking of anatomic issues, looking for or underlying ischemia, obstruction, et cetera, that's where we're doing the CTAs or coronary calcium scorings and are actually, obviously invasive coronary angio. So let's go do a question. I don't think I set up polling ahead of time, but I should be able to use an old poll. So let me pull that up. Okay. So we have a 60-year-old woman who's evaluated for atypical chest pain at 3 months duration. She has asthma, treated with glucocorticoids, but she can walk at a brisk pace without any of her symptoms if she uses her albuterol ahead of time. The results of the exam and the EKG are otherwise normal. So which of the following is the most appropriate diagnostic test? It's going to be the adenosine stress test, or coronary angio, dobutamine stress, exercise stress. I don't remember how many options I have. So those are your three. All right, so we'll end it right there. I'll share the results. The majority of you guys put the exercise stress test, and that's absolutely correct. I don't know why it's repeating. Oh, there you go. So the big thing that it's important for you guys to know about this is, while what the boards are going to test you on are not necessarily what we do in practice, that's going to be the most annoying thing you're probably going to come across as you're studying for the boards, because they're going to test you on what should be done. But you'll know that when it comes to like even endocarditis, do we jump straight to a TEE if we have a high pretest probability and maybe we're concerned about a perivalvular abscess? Not really, even though that's the best one for sensitivity because it's almost 90%. We typically still do a TTE because from a cost of savings perspective, it makes more sense, and it's only, even though it's only 70% sensitive. So what they're going to want you to, sorry, let me see if I can go back. The big things to know is that this patient is able to walk. If they can walk, you let them walk, okay? If they have a history of surgeries to their lower extremities or any reason why you don't think they're gonna be able to meet that Bruce protocol, which I'll talk about, then you're not gonna be doing the exercise portion. But if they can walk, you should always choose that as your answer. So let's get into the actual testing itself. So what is it? Well, it's going to be a diagnostic tool to help us decide if there's potentially an issue and then how concerned are we. So it's a prognostic tool as well. The idea is that we're going to try and induce some kind of ischemic load on that patient. We're trying to recreate either whatever ischemia or pain that they were having, which prompted you to even order this test, or we're going to try and induce an amount of ischemia that you think they should be able to do, because maybe you're doing it from a prognostic standpoint. Maybe this is after they've had a heart attack, they've had stents, et cetera, and you're trying to see, okay, how well are they going to be functioning now? So the production of that ischemia is dependent on two major things. It's on the amount of stress that you're imposing and the amount of just disability or disturbance that they have anatomically. So what I mean by that is if you put them on a stress test, and maybe it's an exercise stress test, and they just walk, there's no grading elevation to it. They're just walking at a flat pace for maybe 2.5 miles an hour, and they have no disease. It's not going to do anything because you're not stressing them enough. They're probably not even going to sweat. Their heart rate will probably stay below 110. But if you have 90% stenosis, maybe in the LAD, and then you put them on a stress test and put on a treadmill and get the incline up to 80%, and they're going at 6 miles an hour, you're clearly going to have two areas that are going to allow you to increase your sensitivity to that test being positive. You're not only going to have a high pretest problem, your LAD was so severely stenosed, but you're truly stressing them from a cardiovascular standpoint. So understand that stenoses, though, that are less than 70% can go undetected, because there's going to be, if you don't stress them enough, you might not get it to the point where that 70% or less than 70%, I should say, is even enough for it to produce anything on imaging, on the EKG that you do, on the echo, on the nuclear. So again, what I'm saying is you have to have both components met. You have to have a significant amount of ischemia, theoretically greater than 70%, for it to have a higher sensitivity or pretest probability of showing up. And then number two, you have to truly stress them either through the exercise that they're going to perform or through the medication that they're going to give. And what are the indications? Again, coronary disease. So maybe they have a diagnosis of stable chest pain, but you're trying to see, is this truly from the coronary disease, or maybe there's a pulmonary involvement too. Maybe they have new or worsening symptoms, or maybe they don't even have coronary disease, but you're trying to look for valvular heart disease. And we'll get into why you're doing echo versus a coronary CTA or nuclear, et cetera, et cetera. But really, when you're doing your echo, cost is a major issue. But if you're going to be as specific and board relevant as possible, what it's going to come down to is when you're trying to look for valvular lesions, or maybe heart failure type symptoms, that's where you're looking for that echo to be performed. So how is it done? Well, it's a diagnostic study looking at the baseline heart function, and then we're going to do a second image, whether it's an EKG before and then EKG after, echo before and after, et cetera, to compare the two. And then remember, there's two types of stress I just kind of talked about. You're going to have your exercise, where you're going to have them induce their own stress by getting the heart rate up, or you're going to iatrogenically get their heart rate up by giving them a pharmacologic agent. And then you're going to have to find, after you've stressed them, how to look at what happened to the heart with that stress, which I talked about with the diagnostic area. You're going to either do an ECG, you're going to do an echo, you're going to do a nuclear, again, which we'll talk about in a second. So think about how you're going to increase the heart rate when you're seeing these patients. Am I going to have them do it themselves? I'm going to give them something to increase the heart rate. And how are you going to look for that actual damage? So if you were to look this on a Venn diagram, it's going to look like two different things. You're going to have your anatomic tests, which we talked about earlier, and then your functional tests. And we're trying to find this middle ground, which there really isn't much of. But the way that we can get that middle is by the stress and the function at the same time and merging them together. And that's how we're going to fill this donut in the middle. So when should you stress or when should you not? This is the primary question that the boards are going to try and get you to answer. That would be kind of maybe a second order question. And the third order question would be, if you have a patient who you think you're going to stress, the first question is you're trying to answer for the second order is, should you stress them or not? Then the third order is going to be, how are you actually going to assess that testing? What kind of test are you going to do? So many of these patients that we have that have acute pain, but really don't have a high pretest probability, if we're going to use our Diamond Forrester criteria, shouldn't be tested. So if they have undetectable troponins, normal ECGs, symptoms have completely resolved, maybe it was with a GI cocktail and they're not a female that's overweight, things that can lead to your atypical presentations, then we have to really diagnose them in the right category. These are going to be either unstable anginas, these are going to be non-ischemic cardiac pains, thinking of sarcoid cardiac syndrome X, which showed up last week on your quiz, and then just non-cardiac chest pain, esophageal spasm and GERD. So when we're answering this question, when we are able to appropriately delineate these patients in the right group, are these true cardiac patients that I have an intermediate risk for, or are they a low pretest probability, which would be all these ones that are showing up in your screen, then you're going to decide, am I going to actually put them through a stress test? Because, which I'll get to in a second, the Bayes theorem, if you guys recall, is going to say that if you have a low pretest probability of someone having something, but then you test them, you're going to have a higher chance of having a false positive, right? And then vice versa. If you have a low pretest probability or a high pretest probability and you test them with a test that has intermediate sensitivity, then you're going to probably get a false negative, which is why when someone has a high pretest probability, we jump straight to an angio. Or we think that they have a PE, you're not going to do a D-dimer. You're going to jump straight to a CTPA, regardless of them going to the ER first or not. So why do we even answer or ask ourselves these questions? Because when we're doing this, we want to determine how effective our medical, or why do we stress, I should say. We want to determine how effective our therapy is. Maybe we put them on max medications and we want to see, is it actually showing some improvement when we put them on a stress test? Or maybe we think they have ischemia and we want to get some diagnostic information for the cardiologist before they go in and do a cath. So this is going to maybe allow us to localize the ischemia and then decide how bad it is, right? Because we know that depending on the location and the extent of the vessels involved, maybe we're going to completely bypass the cardiologist and go straight to a CABG. And then when we do these tests, it's also going to help us feel better about discharging them, which I have kind of blurred out here. But if we were to think about what are the reasons to test, again, as you guys know with my lectures, I'm going to have a lot of slides. They're going to have the same information, but it's just going to present it in a different way. So some of you will be able to grasp information from some slides versus the others. So there's the non-CAD reasons, maybe they have an arrhythmia that potentially is exercise induced. Those are things that I'm going to be dealing with a lot with our CSU athletes. Maybe we're looking for this aortic stenosis type picture. This is going to be big for you guys to remember, the second bullet, because it will come up in your boards. It does make an appearance in Mix-App where they will have someone who doesn't have a lot of symptoms, and then they have aortic stenosis, syncope, chest pain, et cetera. And then they do an echo and the echo shows severe stenosis. Like, that doesn't make any sense. This would be a reason to actually do it, to do a stress test to see, is this a pseudostenosis or not? Or it's the other way around, they have severe symptoms, but the echo is not showing it. And then true CAD reasons, again, looking at the amount of ischemia and then the localization. But if we don't see any of these going on and we have a stress test that is otherwise negative, assuming they did not have that high pretest probability, which increased their risk for, through Bayes' theorem, the high chance that they had a false positive, then we can likely discharge them. So as we know, a lot of these patients are admitted on observation so we can get them out the next day. This is a diagram that I got that was really helpful of kind of understanding the sensitivity and how it goes up versus how it goes down, you could say, depending on how much ischemia or plaque you have. So as we go to the right and we have more and more plaque developing, which is up here, and then we have smaller and smaller diameter that's allowing for the blood flow to the coronary arteries to occur, we see that our sensitivity of some of these tests are going to go up and up and up. So when they have no plaque, they should have normal function. Once you have a little plaque, the most sensitive test you're truly going to have is your nuclear testing. From a financial standpoint, it's not always the best for us to do. If you work at major hospitals, maybe in Denver Springs, it's a lot easier for them to get this nuclear testing done because they don't have to worry about one day of the week being able to get this radio tracer coming into the city. So we did nuclear tests every day at the residency I trained at, and that was our primary thing. We actually hardly did any echoes because it was also easier to get these patients in and out from the hospital versus having the echo person run room to room, and then you have to wait for the imaging to upload, and then you have to have the cardiologist read it. This way, it was done directly in the radiology lab, and we had out as a resident go directly to the radiologist and say, hey, they just had it done. Can you look at it real quick so we can discharge this person? So as you guys go through your career in medicine, and if you become more on the administrative side, you might say at the hospital you work at, hey, I think it's actually more cost effective for us to do more nuclear testing. And you could probably do a QA project, a QI, to see how that would be more beneficial than doing echoes. But I digress. As we get to the decrease in coronary perfusion to the right, then we also see that now we're going to start seeing imaging show up on the echo. So again, the echo is now going to become more sensitive. Oh, whoops, I didn't even have the chat window open. Can you go back to the question? I just saw this, my bad. That's why I want you guys to have your mics. It's better for me to ignore you. So
he just sent it. Can you go back to the question again?
Yeah. D. So do you have a question about that, Dylan? Okay. So let's go back. And then as we go along, then we can start seeing more echo findings, here. And then finally, once the plaque gets really bad, that's where we're actually going to start seeing EKG findings. Don't think that because of this chart, you would not want to then do EKGs beforehand. You still want to do those, right? But what I'm saying is when the patient presents without you inducing a stress on them, that's when you're going to start seeing some of these EKG findings come up. All right, so let's go over our options. So first, you're going to decide what's their risk. and you're going to use a Diamond Forrester. So again, is it non-cardiac chest pain? Is it atypical chest pain, or is it true anginal pain? And I'm going to get to that in a second. And then you're going to find out, based on if it's intermediate risk, then you're going to say, yep, stress testing is probably the most important, because if they were low risk, you're not thinking coronary artery disease. Maybe you're going to do a coronary calcium score, which we'll talk about later. And if they're high risk, you're going to do the angio. So they have to be in that Goldilocks area, that intermediate risk. And then second, once you say, okay, they do have intermediate risk, then you're going to decide, how are you going to look for actual damage? Are you going to do exercise? Are you going to do a pharmacologic agent? And then are you going to decide, once you've decided how you're going to stress them, how are you going to look for the response to that stress? Is it through an echo, ECG, or nuclear? This seems kind of basic the way I'm explaining it, but I'm going to tell you that I don't think this is really basic understanding. And hopefully this allows you to be able to interpret this information and this initial workup a lot easier, because we are going to be the ones on the front lines that have to do this, right? So first, let's go over that pretest probability. So this is Bayes' theorem. It's basically saying, I'm not going to go through this chart, but it's this patient saying that if you have someone that has a high pretest probability of having coronary disease, then you really want to put them more or intermediate to high pretest. You want to immediately do the stress testing or even an angio, just depending on what you talk to with a cardiologist. You know, and again, depending on the hospital, maybe they're not going to want to do a lot of angios. They're going to prefer, despite them having a higher pretest probability of a false negative, then they'd still want them to have an echo done. But you're going to know that if they had a low pretest probability, then your chances of them having a false positive are going to be high. So just know that this optimal Goldilocks zone is right here in this intermediate risk. And then if you go anywhere higher or lower, you're going to increase your risk for false positives and negatives respectively. So diagnostic testing is most valuable when they're in the intermediate risk. And how are you going to determine what that risk is? You're going to use this Diamond Forrester criteria. I think this is the easiest one to use. There's the CAD consortium, the CAS score, the HEART score. We talked about all these when I did my overview on generic testing that's done per specialty about 2 months ago. So I'm not going to go through these again, but just know that you could theoretically use these if you wanted. And this is why the ER uses the HEART score, because they're using it as a way of saying this person has an intermediate risk. I think they need to be admitted for an expedited cardiac workup. Or the HEART score is 4 or less. I think this patient has a low pretest probability. I don't think they need to be admitted. So if you're low, you're going to reconsider your diagnosis, because you're going to say, this person probably doesn't have cardiac disease, or this is not a cardiac issue that's causing their problems. How is it here at Parkview as far as angio thresholds? That was a question that Neil had asked. It's cardiology attending specific, I would say. And I think it would be dependent on the time of the year or week as well. And maybe on the time of the year. You know, early on, if they're trying to get a lot of echoes or angios in, I should say, for their fellows, and even towards the end of the year, maybe if they're getting low on their quota, you're probably going to be more likely to get angios in. But I think there are some attendings that are cardiologists that like to do angios more than they like to do the imaging. So it's completely dependent, unfortunately. So I can't give you a straight generic answer to that. Gestalt is still very much in play. Absolutely. And it's how much you present it to that cardiologist. If you just put the consult in like, oh, we don't know if this person should get an angio first, can you comment? Probably not going to do it. But if you say, hey, this person has come in before with the same exact chest pain, and last time they had this chest pain, they had a heart attack that was noted on the echo, that's probably going to increase their desire to do an angio. If they're intermediate risk based on the Diamond Forrester, which I'm going to extrapolate on the next slide, then you're going to probably say, well, maybe I'm going to do a stress versus a coronary CTA. The coronary CTA is going to come up theoretically when they don't have symptoms, but it has been extrapolated to being a rule out test now in the hospital, but that's still very much under debate. And then if they're a high pretest probability, why even waste their time? Just go straight to cath, because they're probably going to need it. So when you're looking at the Diamond Forrester, the way you're going to interpret it is you're first going to ask 3 questions. Is the pain substernal? Is it brought on by an exertion or emotional distress, which is not mentioned in this chart? And then is it relieved by rest, nitroglycerin? If they're able to answer yes to all 3 of these questions, then this is going to be defined as typical angina. If they answer only 2 of them, it's atypical, 1 non-anginal, 0 asymptomatic. Because why would you even, doesn't make any sense. They don't have any symptoms to any of those. So it's clearly not going to be a cardiac thing. This might seem elementary to bring up, but it's important for you guys to know. And yes, it is a great chart. Thank you, Neil. It's a fantastic chart. Because when it comes to coding and learning coding as a hospitalist or even as a fellow and as an attending a specialist, you guys need to know, you need to specify this in your notes. You need to write patient presents with typical angina, atypical angina, not angina, because those are three completely different ICD and CPT codes that affect our reimbursement for the hospital. Why you might care about reimbursement? Because if you want to make money and be able to negotiate a good contract, you're going to be able to show that you're bringing in a lot of money to the hospital. So knowing your coding is going to help. And I'm going to be doing a talk about that later in the year once you guys are closer to graduating. And then after you've decided 0 or 3 of these questions, then you're going to decide, look at this bottom chart and then say, okay, how many, or you're going to find the matrix that they fall into. So if this person had typical angina and they were 55 to 65 and it was a male, then you're going to say, oh, this is high. So high probability means it's greater than 90%. You're probably going to go ahead and do recommended angio in them. So definitely take a screenshot or just wait for me to send this out to you guys. This is a good chart for you guys to have. I think the Pocket Medicine has a version of this chart in there. And then this is a chart that I had 2 slides ago, but it shows basically the same exact information, but it puts in the likelihood of pretest probability of them having true coronary disease in patients who are symptomatic. So this is just the likelihood of you, or the idea that you should be doing the testing. And this is looking at how many of these patients actually had CAD on cath. And you can see that as you went from top left to bottom right, low pretest probability down to high pretest probability, the numbers got higher as we'd expect. So we've answered number 1. We've decided what the risk is based on the Diamond Forrester. So the next thing we need to do is, how are we going to stress them? This is the largest part of the talk, I think, because it's the most important from your board's perspective. So 2 things we're going to look at is we're going to stress them either by having them exercise, probably not what we're going to do here in Pueblo based on our population, even though I think Dr. Murphy did have a chart saying that Colorado was like the only state in there that was doing pretty good. So, and then we have a pharmacologic option. So again, remember that first line, if you can exercise, they need to exercise. It gives you an idea, not just, that doesn't only just increase their sensitivity of the test being positive, because you're able to recreate the exact symptoms they've been complaining of, because assuming that they've been having the symptoms with exertion. So you can say, okay, well, you have these symptoms of exertion. Let's see if we can recreate them. And then we can look at the EKG to see what it shows, or the echo. But remember that if you do this option, make sure the patients are going to be able to get their heart rate up, right? Don't send your patients who have had bilateral knee replacements 3 weeks ago to have this testing done. Remember your 220 minus age. This is going to be the Duke's criteria, not to be confused with the endocarditis, but this is what they use for, the Bruce, sorry, not Duke's, Bruce criteria, for finding out what heart rate they need to achieve before they've met their criteria for the test to be ended. And remember that it's contraindicated for all these different reasons: severe AS, unstable angina, and obviously if they have the inability to even exercise. Pueblo was not included in that statement. Yeah. Oh, for the, I wouldn't be surprised if they weren't included in that chart. And then pharmacologic. So if we're not going to exercise them, we're going to give them a medication to try and get their heart rate up. So we have 2 options. We have our vasodilators and your inotropes. This will show up in your boards. And the way it's going to show up is they're going to give you a patient, just like I said in that last question, that has mild asthma or COPD. So you should not be using, in general, vasodilators for these patients. But if you want to get into the nitty gritty, if you're going to go into cardiology, like I know Dr. Patel wants to, then, and I know Dr. Pranka, she wants to do GI. You guys want to do all kinds of different stuff. So just know that for regadenoson, it's okay theoretically to do it with mild asthma and COPD. But if you want to make a generic statement, vasodilators, avoid in your COPDers or anyone with a bronchoconstriction, and then instead you're going to use in that your inotropes, your dobutamine for that. When are you not going to use dobutamine? If they have left main disease or suspected left main disease, maybe based off an EKG that you have. If they have hypertrophic cardiomyopathy, AFib flutter, or SVT. And it does require some fasting. So just be aware of that. But it's not really something that you have to counsel a patient on, because when they set up the testing, they'll talk to the patient about that. So the big takeaway from this is just know that if they have COPD or asthma, don't use the vasodilator. If they do, then use the inotropes instead. Again, everyone that exercises can. I'm going to keep saying that because that's how they're going to test you on your boards. And choose exercise stress, ideally in your women with low pretest probability. If you're not going to do a coronary artery and calcium score, if you're not going to look for other conditions, be like, hey, I don't care, this person has a low pretest probability, but I think this is an atypical presentation, I still want to test them. If they are a woman, you should use the exercise stress test because they have a higher chance of false negative on your pharmacologics. So we've done questions 1 and 2. We've figured out what their risk is. We've decided how we're going to stress them. Now we need to look at the actual imaging and find out how are we going to look for those changes to show up after we've given them the stress. So this is a chart that I made that hopefully Neil also likes. It's a type of evaluation of your different stresses. You have your ECG, your echo, SPECT, and then the PET CT MRI. PET CT MRI, I'm not going to spend too much time on because that's really only present. And honestly, Neil, I don't know why it's taking you so long to respond. I clearly asked for you to comment on this chart. Okay, Mathew's dead. Mathew's, I don't think you realize that I can push you into the waiting room, but maybe later I will. All right, so I'm not going to talk about the PET CT and MRI because that's really going to be in your major hospital centers like Denver, Mayo Clinic, stuff like that. Not as much here in the hospital. But the nuclear SPECT, echo, and ECG are going to be the ones that are high risk of showing up on your boards. This is a good one to take a screenshot of. I tried to put as much information as I could. I broke the PowerPoint rule. I could care less, but there's just so much information you guys do need to know regarding these. I'm going to go through each one of these. Just know that the imaging modalities are the last 3. ECG is clearly not an imaging modality. So let's go through echo or ECG. So pretty low sensitivity, still pretty low specificity. The good thing is there's no radiation. And if you can get the person to achieve about 10 METs, then this sentence is important. If you achieve more than 10 METs on this intervention, then it basically suggests that medical treatment, if they truly had heart disease, is as good as a cabbage, regardless of the severity of the coronary disease. So I have the citation on the prior slide if you guys need that. The downside of it is it's not going to be able to localize, and there's a lot of contraindications, and these are what they're going to ask you about. So DIG use is kind of falling out of favor. What are the things that you're going to look for on DIG toxicity in someone on EKG? What kind of changes would you see? Not much heart block. Yeah, tell me about the swoop, Dylan. So where do you kind of see it and what does it look like? There's a maritime reference to it. All right, I don't have time because it's 147 slides.
I forget exactly.
Yeah, so yeah, the mustache. Yeah, absolutely. So, or sometimes people call it the sail sign because it looks like a boat. I'll bring that up on my EKG talk. That usually shows up in like 4, 5, and 6. The other thing is you're going to look for is that yellowing of their vision. So some patients that have DIG toxicity will say that their vision turns yellow. What famous artist was thought to have potential DIG toxicity? Anyone? Van Gogh, there we go. Yep, Van Gogh, potentially. Wolf Parkinson White obviously is a reason you wouldn't want to do the ECG because it's already a baseline abnormality, and then ST depression that's greater than 1 millimeter and underlying left bundle branch block. So let's do a case. 60-year-old male, the Pueblo BMI of 20. Well, actually, no, that's not too bad. No cardiac history referred to the family practice or palpitations. Resting echo is normal, EF of 56%. 2 weeks of palpitation, 2 out of 10 chest pain, physically very active, kayaks almost every day. He signed a worldwide release. Yeah. Post-medical or past medical history is palpitations 10 years ago, but again, cardiovascularly very active and has a history of psoriasis. Doesn't take medications. Blood pressure is pretty good. Physical exam looks pretty normal. No extremity edema. Labs, you see a total cholesterol of 166, LDL 110, TSH is normal electrolytes otherwise. And you see this EKG. I'm not going to ask anyone to look at it, but let me see. Nah, I'm not going to launch a poll on this one. So what I want you guys to look at is take a look right here in AVR. You see some elevation here. You start, So this is their resting, it's kind of normal. And then when they start to exercise at their peak heart rate of 126, which is really actually not that high, but a peak blood pressure 179, which is high, then you start seeing the elevation. Here in AVR, you start seeing some depressions in 2, 3, and AVF, and then you see some reciprocal depressions as well in 4, 5, and 6. So maybe there's some right-sided involvement that we're not able to, and then even some elevations in 1 and 2 as well. So, I don't even know why. Did I launch? No, I didn't launch the poll. Okay, I just want to make sure. Yep, ST depressions, completely agree. So this person, they went through an exercise ECG. They saw these abnormal findings. Remember, I said less than or greater than 1 millimeter is what you can't have on baseline, and he didn't have any on baseline, but he developed it after the stress test. So they did an angio, and they found multivessel obstructive disease, 35% in the main with almost 95% in the LAD. Diagonal had 50% with the left circ and obtuse marginal of 80 to 70 respectively with the RCA. So diffuse disease everywhere, right? So what are the high risk things? Why did I bring this case study up? Because what are the things you're looking at if you want to learn how to get credentialed on stress ECGs? I know Dr. Duffy has credentialing in that. I got it when I was a resident, but I don't do it anymore. You're going to be, the high risk features is they just don't meet that Duke and Bruce score, right? So they're not able to even get high. The time to onset is very low. So before you even get them sweating, they're already showing ST depressions. Their blood pressure is dropping. Maybe they're already having some symptoms. A new bundle branch shows up. Cyanosis would really kind of tighten your sphincter there. Or if they have an exercise-induced ventricular rhythm. So these are all kind of obvious things. They're not going to ask you about specific millimeter depressions on the boards. They're just going to make sure that you understand that if you see it, that's clearly not a good thing. And what are these depressions, or what's the progression that you would see during an ECG? Maybe you're not going to see any. You're going to start to see less than 1 millimeter, and then it's eventually going to progress to, that's a kind of equivocal, but I'd say it's pretty noticeable. And then a positive response is when you start seeing this downsloping. So I'd say these, even though it says it's equivocal, if you saw this middle and then this last one, these are going to be very concerning to you. So the exercise ECG is really going to be a procedure of choice in patients who have never had coronary revascularization, because if they've had that, they know they have some amount of disease, your pretest probability is going high, you're probably going to want to be able to localize better. And we know that the ECG is not going to localize that. We're going to have to do a nuclear plus or minus an echo. The echo is really not going to help you localize as well as a nuclear would. So if you have someone that's had a CABG or revascularization before, you're pushing more towards the echo versus the nuclear testing. The advantages though, as we talked about, it's low cost, it's available, but it does take a lot of time. So that's why you're not going to send everyone here in Pueblo to get an exercise ECG, because there's just no way they'd be able to get all these done. They can do echoes and nuclears a lot faster, and it's better reimbursement for the hospital, to be honest with you. So when should we add that stress imaging though? Because we mentioned that the ECG is not imaging, right? It's just a different type of appearance, but it's not true imaging. SPECT, nuclear, CT, MRI, PET, those are our nuclear and echo. So when will we do it? If someone cannot exercise and they require some pharmacologic stress, because you're not really going to give them adenosine and then do an ECG after that. So when you give them that pharmacologic agent, you've pretty much binded them to getting an echo or a nuclear. Again, if they've had prior revascularization and you really want to be able to localize to see if this is the exact area of involvement where they were having it before, or if they have some ECG abnormalities. What about in patients with a history? That's not a contraindication to doing it. I would say that if you have someone that has a history of diabetes, your pretest probability is raising or going up, and maybe they're already going to have, as a result, maybe some baseline ST or TF changes, which would preclude you from being able to do it. But you shouldn't use that as a reason why they cannot get, or why they should go straight to stress. Okay. So things that you would want to do imaging. So these are the contraindications for the EKG. If they have a left bundle branch block, if there's clearly a paced rhythm, if they have an abnormal ST segment at baseline, it has to be greater than or equal to 1 millimeter. That digoxin effect, that mustache sign, the sailboat, here's the boat, and then the sail is the R wave, if you can see that. LVH with repolarization abnormalities, meaning that you have like this J point potentially change with some inversions as well. And then Wolff-Parkinson-White, where you have that slurring up of the R wave. Can we see a sail sign again? No. All right. All right, I guess I'll go back. So here's the, I think I can draw. So let's draw. Let's have, oh, son of a, let's do red. Let's make it, there we go. Here's the boat, and here's the sail. Does that appease you, Mafoos? No. All right. I don't care. How do I mouse? Okay. So let's keep going. So we talked about ECG. And now people are singing, that's great. And now let's look at the echo. So it has a little better sensitivity, better specificity. Remember, echo EKG was like 50 to 60 and maybe in the 70s for specificity. So echo is going to be higher. There's still no radiation, but it's a higher sensitivity. It can tell you more about the valves. And then the chamber size as well. It can even give you some idea of pulmonary retention. If you recall that talk from Dr. Garcia, he was saying that really once they get into the 50s range, are we going to potentially even call it, but not really the 25, which we know of for the right heart cath. And it's a lower cost than doing a nuclear scan. But the problem is it's going to be very dependent on the technician and the patient, right? If they're very obese and you have a lot of fat that you have to go through, it's going to be hard for you to even see anything. And if they have resting raw motion abnormalities, you're not going to be able to see as much on there. So the idea is that how are we going to find that imaging or the abnormalities in the heart? We're going to look for this regional wall motion change, and we're going to compare that to an echo before and then an echo after. We're going to look for it's not going to tell us the anatomical theoretically. Some of them, providers can theoretically, think about, oh, it's on the septal, maybe it's the left main or LAD involvement. But it's really just going to tell you the functional significance if there truly is CAD, because maybe they have CAD, maybe it's 90%, but functionally it's doing absolutely nothing. It's not decreasing their EF, they're not having symptoms. So maybe there's no need to actually intervene. So that's the reason why the echo could be beneficial. Contraindications are going to be the same as the left bundle, because it's not going to be able to get that contraction as well. So it's going to affect their ability to compare the before and after. True HOCM, because we know that the septum is going to be involved as well as the left main or the left ventricle. And then Wolff-Parkinson-White, because again, this type of arrhythmia is going to affect their ability to see the echo since it's based on the pacing of that PQRS. Limitations, operator dependent, lung disease, and then breast implants. These two things are going to be impairing the ability for the ultrasound wave to actually penetrate to the heart. Things you're looking for when you see that stress echo and then you're reporting it to your upper resident saying, hey, I think this patient can be discharged. What are the things that would preclude them from being discharged? Well, if there's global left ventricular impairment, if they have any evidence of diastolic dysfunction that's showing up, there's dilation or dilatation that's showing up on that left cavity after they were stressed out, or there's new mitral regurg. Because the mitral regurg is going to be suggestive that maybe there's some papillary muscle involvement. Maybe you're going to have some splinting of the papillary muscle, which affects the ability for the valve to close completely. So then you're going to have a regurgitant jet that results from that. So, but when would you want to do maybe a SPECT, so the nuclear test? Well, SPECT is better in those patients who have known or you have a very, very high pretest probability, like Max was saying, maybe they have diabetes, of having coronary disease. So new diastolic dysfunction with exercise or at rest. So that's a good question. If you have diastolic dysfunction, this is going back to not just stress testing, but any echo. If you suspect even on like a diastolic murmur, that's when your indications, regardless of the grading severity, because we know that grades 3 out of 6, okay, that's when they should get an echo. 2 out of 6, not as much of a concern. But if you have any diastolic murmur or diastolic, that's when we're going to get concerned. If you see diastolic dysfunction with exercise, that's when we get concerned. Not as much with rest. That's when it occurs with exercise and it wasn't present on the resting echo. So echo gives you better data on the valve function, but remember the SPECT is going to give you more anatomic localization. And we have those two options. You have the dobutamine, which is inotrope. That's going to be good for those patients that have underlying bronchoconstrictive disease. Your adenosine and dipyramidol is going to be good if they don't have that. I think I have a chart towards the end of the cost, if that's a question that's coming up of which one's more expensive than the others. Okay. So nuclear SPECT has very, very high sensitivity, 82 to 88%, and very high specificity as well. But the cons is that you're exposing this patient to radiation. Sometimes these patients are given a card that they can use if they're going to go on a flight soon, because they are going to show up as having being radioactive. So especially if they're doing international travel with the state of global affairs right now, they're going to have that card when they go through TSA. It may not catch balanced ischemia. So know that if there's just enough ischemia that the heart is compensating for, if you don't stress them enough, it's not going to catch that, okay? So that's a question that's going to come up, and it can be hindered still by breast size as well. So again, if you think that there's an evidence of balanced ischemia going on, that's going to be based off your gestalt that was brought up. You're like, hey, I don't believe this echo finding. This person, I definitely think they have it. That's when you're going to talk to your cardiologist to discuss whether you should go after an echo or angio. So it uses this isotope that's retained in viable tissue. All right, so it's important to know. If that tissue is viable and it's not infarcted, then you're going to see that radioisotope stay in there. But if it's infarcted, that isotope is going to leave, and then you're going to see it kind of get dark, and that's what you're going to look for, that the difference. You have a lot of different isotopes available. The intent of this talk is not to go through all those, but you will if you become a cardiologist. And it produces an objective 3D map of the perfusion. So we have the rest of the bottom, these little donuts, and we see what they look like, and then we compare it to the top. I'm oversimplifying it. So, but if you can see that here at rest, we were able to have that viable, or what appeared to be viable tissue, take up the radioisotope, but then when you stressed it, that tissue wasn't able to keep it and it went away. This would be the area that we're seeing the ischemia. And it's not just in one image, it's in multiple images. So just like with your EKGs, you want to see the multiple leads, or ideally anatomic connected leads, you're seeing this appear in multiple leads here, which is suggestive of this being a positive test. Clearly, when you stress someone out, if they're normal with no cardiac disease, you're going to see the exact same donut appear on both sides. This just shows you an anatomic, or a way of looking at it anatomically, because it's not easy to be able to look at this chart and be like, where are we in the heart, right? So we now look at this and we take a subsection, we can see how we can get the donut view. If we take a cross section here, which is more of like a sagittal cut, then we can see, like the horseshoe or D view, and then we can see an upside down like horseshoe view if we're taking more of, transverse cut. So this is another image that I found that I thought was very helpful of being able to use a short axis, vertical, and horizontal long axis. Again, just showing you how you can use this imaging to analyze and localize, the area of ischemia based on this. So this would be another one if you guys want to save when you go on your cardiology rotation, if you guys get a chance. I don't know if you do get a chance to go through these with the cardiologist or with the fellows, but this would be a good one to kind of have printed out in color so you can localize the findings for someone. So let's do a case. 69-year-old male, a lot of family history, has a recent chest pain, but a difficult historian, just like the case report from Chase yesterday. He does have a history of cancer. Just know that when cancers come up in your cardiac patients, the ones I really care about are your breast cancers or thyroid, or any ones that required systemic radiation like doxorubicin, or radiation directly to the chest where it's going to induce potential heart failure, right? They're on what appears to be all the right medications. I don't see a statin or anything on there, but maybe they don't have hyperlipidemia. Blood pressure's high, normal exam, no leg edema. You do a normal resting EKG, you do an exercise ECG, and then you say, wow, this is really bad. We're seeing some elevations in V1, not much in V2, not much in 3, maybe some depressions in 2, 3, but I definitely see some in AVF. So they decide to do a nuclear test. And on this person, you can see the resting is at the bottom, the stress is at the top, and these go in pairs of 2. So you can see one that just jumps out to me right here is on this donut view, looking at kind of the apical region. We can see that there's a loss of that perfusion or that retained isotope here in that right side of the patient's body. So it can help you decide, the identification of it and localization. So this patient had a large, severe reversible defect involving the anterior wall septum apex, pretty much their entire heart. And a cath confirmed 85% mid-LAD stenosis, which would cause effects to all portions of this heart if that area was involved. So this was just an actual case that I want to pull up where you can see when you're comparing the stress and rest on all the images, there's abnormalities in all of them. Oh, that one made it easier for me. I forgot I had that, sorry. And then stress reporting, what it's going to come down is it's either going to be normal. So if you get the report back, how do you interpret it? It's going to either be normal, it's going to say there's a fixed defect, meaning that they have infarcted, and potentially it's just too late at this point. Maybe they have a reversible defect, so maybe there's something you can go in and fix it, and a mixed defect, meaning they have some reverse, some fixed. Maybe you're going to be able to do it. You're going to look at the patient's surgical risk to decide if it's even worth going into. Does CTO show up on Lexiscan since there can be collateral? That I don't know. If it would show up in the Lexiscan SCARI. I will write that down. I'll write that down and let me see if I can get back to you on that. High risk features to look for on someone that has the nuclear scan done. Is there a large reversible perfusion defect? Because clearly that's something you can do something about. If there's multiple perfusion defects, if there's an abnormal post-stress EF ejection fraction, so obviously the ejection fraction dropped after stress, that's going to be concerning. And then finally, the PET, CT, and MRI. These have the highest. These are going to be, other than your angio being the gold standard, this is going to be just as, almost as good, because you're not going to have to succumb the patient to the risk of getting an angiogram done. highly sensitive and specific. It's not going to be affected by the breast tissue, the obesity, the things that are going to affect our nuclear and our echoes, but it's very costly. And unfortunately, we just don't have a lot of the ability to do that here in Pueblo. We do it, but not all of our patients are going to get it. And because of the fact that they're going to get some kind of contrast, you should not do it in your patients with CKD, which a lot of our patients that are going to be tested for coronary disease probably have some CKD. So the high risk features that you're going to look for in someone that had a PET CT or the MRI, you're going to look for late gadolinium enhancement. So just like we saw with this nuclear, that we saw that perfusion went away and then it just wasn't present at the bottom, which is suggestive of there being a defect there. We're going to look for the fact that they have, late gadolinium enhancement. There's going to be evidence of reversible defect. There's going to be, 3 vessel disease, left main stenosis, all these things that are kind of obvious of we should probably send them for our cath. So if we look at all these, and this is where I brought in, I try to bring a table, and the next one will be a flow chart showing the sensitivities up front against each other. ECGs are falling out of favor because they just take too long to do, but boards don't care about that. The patient can exercise, you should still do it. The echoes are good because they can give you function information. Is that ischemia affecting that patient from a functional standpoint and depressed EF? But it's dependent on how good your technician is and the patient's body habit is. Nuclear is good, but it's going to misbalance ischemia, as well as the patient's going to be exposed to radiation. And PET CT and MRI are really good, but they're very expensive and not that many hospitals have them. And here's an overview of the sensitivity. So the angio is going to be 91%, 93% specificity. It's again going to be operator dependent, right? There's higher risks as well because it's more of an invasive study. And then the sensitivity is going to drop as we get farther away from our imaging modalities. So this is a flow chart that I made for you guys to kind of summarize. I have 7 minutes and there's no way I'm going to finish all this. I have plenty of lectures I have to film in for next month. So I'll do a part 2 of this for next month. So if you have a patient that presents with chest pain and they can exercise, then you should have them exercise. And you can see that a treadmill, these are not numbers for Pueblo, okay? But some of you guys recall, if you saw over here last year, I had a similar chart. I did make some modifications to it, but it's a lot cheaper. But once you add that SPECT imaging, your cost is going up, exponentially. If they can't exercise, then you're going to have them get a pharmacologic agent to cause that heart rate to go up. And it's either going to be a vasodilator or your inotrope or your beta agonist. Remember, inotropes are okay for your COPD and asthma. Vasodilators, you're going to avoid for that. But if you want to be specific, regadenoson can theoretically be done for both, all right? And then once you know that you have your agent that you gave them, now you're going to add an imaging to be able to see what happened to the body when you gave them the agent. And we can see that the SPECT nuclear is going to have the highest or some of the highest sensitivities along with PET, but it's going to have a higher cost associated with it. But the echo, when you compare the sensitivity, you can argue that is it worth over doubling the cost, almost tripling, just to get an extra 7%? That's a discussion you have to have with your patient and the insurance companies. So if we were to put this all together into one chart, I like charts, you would say if a patient is able to exercise and they have a normal ECG, then you should give them an exercise ECG. If they're able to exercise, but they have baseline ECG abnormalities, then you're going to do perfusion imaging. So you can still do an exercise ECG, but you're going to add some perfusion imaging, or you're going to just do an exercise echo. If they cannot exercise from this point forward, and they have some resting abnormalities, a left bundle or it's pace, then you're going to do that dobutamine. But if you want to do the nuclear and between the nuclear and the dobutamine, the major difference here is that if they have AFib, flutter, or they have major obesity, you're probably not going to do the echo. Remember, the echo can still be affected by it, but this is going between cost between these two options. And if they have active asthma and COPD, then you're going to try and avoid your vasodilators and use dobutamine specifically. Let's see, I have time for one more case and then we'll call it. So a 70-year-old male with diabetes, hypertension, and COPD at home oxygen. They did quit tobacco in 2014, was recently evaluated by family medicine for worsening shortness of breath for the past 2 weeks. Which of the following is the most appropriate? So this one I can do a poll for, so let's relaunch it. So are you gonna do a treadmill in this person that's on oxygen at baseline? Are you gonna do a treadmill with stress? You're gonna do a treadmill with nuclear? Are you gonna give a pharmacologic agent? You're gonna do a dobutamine stress or a coronary angio? So I have, yay, 3 results. Oh, almost 4. So the majority of you guys put E. So the answer truly is actually D. It's dobutamine stress echo. Oh, too fast. Yeah, I mean, it's 12:56 now. So, I know. I mean, you can get the answer to yourself. No one's going to know. So in this patient, they have clearly a lot of risk factors. They have COPD. So we're not going to be doing regadenoson. Okay. We're not going to be, they have worsening shortness of breath for the past 2 weeks. We know that they have a high pretest probability for, oh, sorry, E. Oh yeah. So I was thrown off by I didn't have F as an answer choice. So I guess if you wanted to do angio, you couldn't. So you guys, majority, you got it right. You know, because there's no need to jump straight to angio because we're not hearing enough. They're not hearing of anginal pain. The patient goes, you know, going back to your Diamond Forster, they start exercising and that's when they get the chest pain and then goes away with the rest. We're not hearing that high pretest probability. So we're like, maybe this is high to mid. So we know they're not going to do treadmill because this person's on oxygen. There's no way that they're going to be able to even meet the criteria. So A, B, and C have to be out. Not Blaine, she was going to pick D. Yeah, I agree. So now your options are really going to be between D and E. So are you going to give them a pharmacologic agent and then look for imaging on the nuclear, or are you going to do a stress echo? And in this person who has, you know, these risk factors, I would say that I'm not really looking for localization, and they didn't have a history of coronary artery disease or revascularization, which is when I said you'd want to just jump straight to the nuclear perfusion imaging. So that's why the echo would be the best option, because they don't have that history. So you're not looking for localization. You're just trying to see, do I see any wall motion abnormalities? And if I do, then maybe I'm going to go then to the angio, or maybe at that point, you know, cards would want a nuclear. But hopefully I explained that thought process. So A, B, and C are out because this patient's on home oxygen. F is out because the patient doesn't have enough I didn't give you enough HPI information to jump straight to angio because they didn't have those Diamond Forster criteria that I talked about. And then when it came between D and E, you're really deciding, should I do nuclear and echo? And the only time you're really going to do nuclear on the boards is if the patient had a prior revascularization and you're trying to localize that ischemia to not only help for the angio and to find out, is that ischemia they had before and that obstruction the same amount that we're seeing right now on that nuclear? So hopefully that kind of made some sense. And I think this highlights it. So we're not going to do the second case. It is 12:58. So I finished at slide 85 and there's 147. So more than halfway. I'll take that as a victory. We will continue this at a later time. I'll look at my schedule, and then when I send out the slides, well, I'll wait to send out the slides to you guys when I finish up, because there are more questions I don't want you guys to know ahead of time. And then once I figure out the date, I'll send it out as an email so you guys know when part 2 is going to happen. And then we'll do the EKG talk. I have that set up in 2 parts, but I don't know if I'm going to be able to do it in 2 parts. But if I have to, I can extend that to a 3rd lecture. Just as I'm not going to do a poll, but just using the chat room, was this helpful as at least in an introduction to diagnostic testing? Because I think it's, you know, something that you really don't get a good chapter on or a video on. So that's why I made it. No, you can't say no, because if you do, I'm going to see it. And then Dr. Braden is literally 10 feet away from me. Yes, Neil, the charts were good. Great, actually. Okay, awesome. Thank you very much, everyone. And you are done for today. And we will have a talk tomorrow will be nephritic and nephrotic syndrome, and Blaine will be kept in the waiting room for that. All right, thank you.